down to the important stuff. You guys all know how to get a hold of me, right?
Yes.
You guys all have my cell phone number?
Yeah.
Somebody say no?
I said yes.
Okay, anybody not have it?
I'll share it.
Okay. All right, and did everybody get their books?
Not yet.
Not yet.
Okay,
So
so
what are you missing? Is it the
All of them.
the pharmacology or the local anesthesia or both?
Both. I have local, but I got it on.
Okay.
So that's the only reason I.
Okay. We'll probably be fine based on the fact that, you know, I've got a lot of the important stuff on the PowerPoints. You know, the books are nice because they're an adjunct. You know, it's like it's not the end of the world if you don't have it, but it just helps. Okay, so if you want to read the chapters and you want to borrow from other people, that's fine. Both of these books are the same from last year. They have not updated things yet. So, you know, if you can get a hold of a used book or something, you know, that's perfectly fine. But don't sweat it if you don't have it right away. Okay? All right, so the important stuff is how are you going to be graded? Okay? I have, you know what, let me fix this light a little bit. Years ago, when you guys took tests in pharmacology and oral path and all of those, you had to get a 70 on every single test, and if you didn't, you were out of the class. Okay? I don't think that's quite fair because things happen. Okay? So you just have to have a 70 in total to pass the class. Okay? So if you do badly on, can I help you? 141 is in the sim lab. Yes. So where was I? Oh, so you know, if for some reason you don't do well on one test, it's not the end of the world. Okay, you're still going to be able to get through the class. There are quizzes. I'm trying to remember if I have 6 or 7 quizzes. I'm going to do the same thing like I did in oral path. So your 2 lowest quiz grades will be dropped. As you take an exam, any of the quizzes that you took before that exam, so if you had quiz 1 and 2, and then you take exam 1, if you do better on the exam than you do on one of those quizzes, then I will exchange your exam grade, or that quiz grade, for that exam grade, okay? So that'll help you out as well. There are 3 exams, and we'll look at the schedule here in a second. None of them are comprehensive per se, okay? You're going to be learning things, and then we're going to have the exam. The first couple of lectures that we have today and next week are kind of building blocks. So there's some definitions we're going to go over, terminology, some concepts that will be discussed throughout the semester when we actually specifically look at drugs. So obviously those may be on future tests. But if I talk about hypertensive drugs now, it's not going to be on the last exam as well, okay? It's going to be on just each individual exam. So think of it as 3 midterms, not 2 midterms and a final. Grading scale is the normal grading scale. And then we've got all of the learning objectives, and I believe that's all that we really care about. Okay, like I said, it's the syllabus is the same as all of the other syllabi. When we look at the schedule is always up for some change depending on weather. You know, it was kind of nice well, that's the only thing that was nice about Zoom, was that if the weather was bad, we could still hold class. So if for some reason the school is closed, we may have to change things up a little bit, but as of right now, this is how the schedule is going to be. Quizzes will be done in class. So when you first come in, they will open up at 8 o'clock, and then you'll take the quiz, and then we can go over the quiz, and then we'll start into the lecture, okay? Exams will also be in class. The exams, you will still have that lockdown browser. So when you go into the exam, it'll have that, but you don't have to worry about the webcam thing because I'll be your proctor. Okay? All right. Some of the things that you're going to learn in this class we're gonna be using in pain control. So we couldn't fit like the drugs that we use in pain control within the pain control class. So we will actually be looking at local anesthetics in this class, and then you're gonna be using that information that you learned in pain control, okay? We're also gonna do nitrous oxide. We'll have the lecture here, and then the lab portion will be in pain control, okay? And so that's pretty much it. Any questions about the schedule? Okay, and before I forget, this is actually about pain control. Someone had asked me yesterday if you guys had to wear scrubs, and I said yes. The more I thought about it, it's like, no, you don't need to wear scrubs, okay? Just make sure that you have the lab coat and the regular clinic type shoes, okay? So you can wear street clothes, just make sure you have your lab coat and your clinic shoes, okay? I just want to say that just in case I forgot about it. Okay, are we ready to do the lecture? All right, so this is going to be a shorter lecture. I split up the building blocks lectures. I split it up into two just to kind of slowly ease you into pharmacology. Can everybody see this screen okay? Do I need to adjust the lights? Everybody good? Okay. I tend to walk around the room. That's the other thing I hated about Zoom. I was stuck in a chair, okay? So I like to move around. You don't have to follow me. Okay? You can look at the screen. But I'm not a school marm kind of person where I have to stand in front of a podium and lecture, okay? I don't like that. So, again, we're going to start out looking at some terminology. Fix this. Maybe. Okay, I guess that's just fix this. Okay, so first of all, we have different objectives that we want to look at. And the first objective is that we're going to look at the difference between pharmacokinetics and pharmacodynamics. And we're going to look at the principles of when a person takes a medication, what does that medication do, and what does the body do to the medication? So we're going to look at how the medication is absorbed by the body, how it is available to the tissues, and how it gets metabolized. So pharmacokinetics is the study of how the drug moves through the body. All right, so it's looking at when someone takes a medication, what does the body do to that medication? How does the body absorb that medication? How does it get distributed throughout the tissues of the body? How is it broken down or metabolized? And how does the body get rid of it? So when we think of pharmacokinetics, think of what the body does to the drug. When we look at pharmacodynamics, now we're looking at what the drug does to the different target organs. What is the mechanism of action of that drug? How does it work? Does it have receptors? Does a body have a certain receptor that that drug needs to bind to? What happens when we take specific doses of that medication? So if we take a therapeutic dose, if we take too much, if we take not enough, what does that do to the body? And then sometimes if we take too much, or the body could have some sort of a reaction to that drug, and we could have some toxic effects. So we'll look at all of that. So when you think of pharmacodynamics, think of what the drug does to the body. So pharmacokinetics, what the body does to the drug. Pharmacodynamics, what the drug does to the body. Some other definitions we want to look at. Posology is just the study of dosages of drugs. So if you have a drug, let's say for example, penicillin. If you take 100 milligrams of penicillin, what is that going to do? If you take 250, what does that do? If you take 500, what does that do? What dose is necessary to receive the therapeutic effect? What dose is going to cause toxic effects? So that's all related to posology. Toxicology is just the study of poisons and pollutants, but it also looks at some undesirable effects that occur from drugs. So there are going to be times that people are going to take medications, and again, if they take too much, what kind of toxic effects can occur? But sometimes some individuals, their bodies can't handle those medications. So those medications could cause effects such as an allergic reaction or something along those lines. Sometimes drugs can cause death. Think of an antibiotic. Someone takes an antibiotic, they're allergic to it. That allergic reaction is considered a toxic effect. That allergic reaction could be minor. The individual could get a rash, or it could be severe. They could go into anaphylactic shock and die. The other thing we want to think about is that, when you think of poisons, you think of the bottle with the little X on it, or the skull and crossbones. But medications can be poisons too. So if you take aspirin, someone takes low dose aspirin, it has an effect. If they take the regular dose of aspirin, it has an effect. If you take a bottle of aspirin, you have poisoned yourself. Okay? All right, so let's look at the difference between chemical, generic, and brand names for drugs. So this is going to take you back when you guys had to do that drug reference in medical emergencies to prepare yourself for clinic. And I said some of you it's going to be difficult to really know for sure if you've got it right. And so we're going to look at how the drugs are named. We're going to look at classifications and that sort of thing. Okay? So when we look at drug names can be based on their chemical makeup. It can be a generic name, or a company can then attach a brand name that is only from their company. Okay? So for example, we could have a drug that's chemical name is N-acetyl-P-aminophenol. All right? Nobody goes to Walgreens and says, I need a bottle of N-acetyl-P-aminophenol. All right? You may go to Walgreens and ask for acetaminophen. So acetaminophen is the generic name. What is the most common brand name for acetaminophen?
Tylenol.
Tylenol, yes. So, you can get the brand name, you can get the generic name. Typically, they're exactly the same. Sometimes certain individuals will react differently for brand names and generic. They may not get the result. But typically, you're looking at the exact same makeup. Generic obviously will be cheaper than a brand name medication. That's why a lot of insurances, when you have to get a prescription, they'll pay for the generic, but they won't pay for the brand name, because the brand name can be 10, 15 times more than what the generic is. So, when we look at chemical structure, we're going to look at classifications of drugs. And remember when we were looking at the classifications, there are different ways that drugs can be classified. They can be classified based on their chemical structure. So there are certain classifications of drugs that will have the same base portion that will be when it's made up of its chemical structure. Some drugs are classified by their mechanism of action, how they work. Drugs can also be classified by their site of action. Is there a specific target organ that this drug is designed to work on? And they also can be classified by their primary effect. And all of these can be interrelated, and we'll look at that here in just a minute. So let's look at the drug epinephrine. We know that our bodies produce epinephrine, it's usually called adrenaline, but there's also epinephrine that can be given to an individual. We learned about that in medical emergencies. Sometimes we have to give them epinephrine. So if we look at the chemical structure of epinephrine, it is a catecholamine. A catecholamine is a drug that contains an aromatic ring. We're going to look at that a little bit later, okay? So some drugs will contain this aromatic ring that has these hydroxyl attachments, and some don't. If they have that ring with the hydroxyl attachments, it's going to be a catecholamine. And that's important because we're going to look at how catecholamines are broken down when we look at metabolism. If we look at the mechanism of action, epinephrine is an adrenergic agent, specifically an agonist. We go back to head and neck anatomy. We learned about the sympathetic and parasympathetic nervous system. I told you that it would come back to bite you because you're going to have to see it again. Guess what? You're seeing it again. All right? The adrenergic nervous system is the sympathetic nervous system. So if we have an adrenergic agent, the expectation is the mechanism of action is it's going to affect the sympathetic nervous system in some way. Okay? If we look at the site of action of epinephrine is those adrenergic receptors. So the beta 1, the beta 2, and the alpha receptors. And when we look at the primary effects, if we have a drug that stimulates the sympathetic nervous system, we would expect sympathetic results. Sympathetic results would be increase in force of contraction of the heart, increase in the heart rate, vasoconstriction from the alpha effect, and bronchodilation from the beta 2. So the heart's the beta 1, vasoconstriction is alpha, and bronchodilation is beta 2. So when we see these can be interrelated because we know an adrenergic agent binds to adrenergic receptors and causes adrenergic results. All right, so let's look at codeine. We look at the chemical structure of codeine. It's an opioid. Its mechanism of action is that it is an agonist at opioid receptors. The site of action is specifically the mu and kappa receptors, which are opioid receptors. We're going to look at this when we look at opioids later in the semester. Mu and kappa. Its primary effects is analgesia. Okay, people take codeine for pain. Agonists, we're going to go into agonists here in a minute, but basically an agonist is a stimulator. So an agonist is going to cause an effect, whereas there's something we're going to look at, it's called an antagonist, that will prevent the effect. Okay, so when we look at receptors, we're going to look at that. All right, so let's look at drug effects and indications. We're going to look at potency and efficacy, and then we're going to look at how those work when we look at a dose-response curve. All right, so now we're looking at pharmacodynamics. And what did we say pharmacodynamics were?
The drugs happening to the body.
What the drug does to the body. Okay, so we want to look at drug effects versus indications. Now, sometimes those get a little bit confused because they're very close, but they are a little bit different. So the drug effect is exactly what the drug does to the body. The indications would be why you need to take that drug. So think of a medication for hypertension. The drug effect would be lowering blood pressure. The indication would be hypertension. Okay? We're also going to look at action versus side effect. Drugs will have a primary action, but quite often drugs will have other effects as well. And then we're going to look at sometimes those side effects are adverse side effects. So these would be undesirable effects. So this could be a toxic effect, this could be an allergic reaction, something that's undesirable. Toxic, allergic. And then dependency is also an adverse side effect. Don't confuse dependency with substance abuse. Okay? When someone takes a specific medication and they take it over a long period of time, the body changes. And when the body changes, the body can start to become dependent on that medication. So you may have an individual who has chronic pain and is taking an opioid for that chronic pain. Because of that, they're taking that opioid for a long period of time, their body starts to become dependent on that opioid. It's still therapeutic. So they're not doing illegal things to get this drug. Now, unfortunately, sometimes when people do get dependent on that drug, then they start doing things that are illegal to get more of that drug. Okay? You also have individuals that take a specific drug that don't need it. So that's when you start looking at substance abuse and addiction. Okay? And then there are some just weird side effects that, individuals will just have some weird effect that is not in the norm of the expected side effects for that specific drug. All right, so when we look at action versus side effects, we're looking at a dose-response curve here. And this is a dose-response curve for aspirin. So when an individual takes aspirin, there are some therapeutic reasons why people take aspirin. When they take a low dose of aspirin, they're taking it for the antiplatelet effect. If they take a little bit stronger, like a regular strength or an extra strength aspirin, it's typically being taken for pain relief or for fever. But once you start taking over that therapeutic dose, so you start taking too much of that aspirin, then you're going to start getting some side effects that are not good. So these are the undesirable side effects. So first of all, you'll start getting some ringing in the ears. The individual can then start hyperventilating. They can become dehydrated, and it could result in death. So aspirin has good effects and it has bad effects. And it's all related to the dose. So how much you're taking. So when we look at drug effects and indications, let's look at the drug atropine. You guys remember atropine for medical emergencies? Mm-hmm. Yes. Do you remember what we used it for? It was for hypotension and low heart rate, right? Okay. All right, so let's look, what is the primary effect of atropine? The primary effect is it increases heart rate. There are some secondary effects of atropine. Secondary effect is it increases blood pressure. So if you just wanted to increase heart rate, but the person had high blood pressure, you may not want to give them atropine because that's just going to make the blood pressure get even higher. So this could be a bad side effect. It could also be a good side effect. If you have someone who is hypotensive and has a low heart rate, you give them atropine, the primary effect is to increase the heart rate, but it's also going to increase blood pressure. So that's a good thing if the blood pressure is low. If the blood pressure is high, it's a bad thing. Another side effect of atropine is it causes dry mouth. That may or may not be a good thing. And nobody likes to walk around with dry mouth. It's uncomfortable. But if you need to have a dry mouth in order to do a procedure and you don't want to have to be sucking spit the entire time, sometimes you may give an individual atropine right before a long appointment to keep them dry. There's better drugs than that, so typically they don't give them atropine. It can also cause urinary retention. So it can cause some difficulty for them being able to pee. So what's the indications for atropine? Bradycardia, number one, but also hypotension. All right, let's look at another drug. Called Valium is the brand name and diazepam is the generic name. We look at the primary effect for Valium is it causes sleep and it helps with anxiety. So if someone is having difficulty sleeping, they may take a Valium in order to help them sleep. If someone is very anxious during the day, sometimes they need to take Valium just to kind of calm them down a little bit, just to get through the day. So some secondary effects, one is sleepiness. So if someone wants to go to sleep, and the side effect of Valium is it causes sleepiness, that's a good thing, right? If you're trying to go to school, and you're anxious, and you need to take Valium to calm you down, you come to class and fall asleep, that's a bad thing, okay? So side effects can be good, they can be bad, or they could be not a big deal at all. They can be no effect. So another thing that can cause is lethargy. So you're kind of, what you guys were when you walked in this morning, especially if you didn't have your coffee. Because someone spilled it. And then it can also cause forgetfulness. Okay, so forgetfulness may be good or bad. Years ago, when we did IV sedations in the dental office, we gave individuals Valium. The nice thing about Valium is they would have this thing called retrograde anesthesia, or retrograde amnesia. And with that, what happened is, even though the patient was awake for the entire appointment, and you could talk to them as you were working on them, they had no memory of that appointment when the medication wore off. Okay? So forgetfulness is a good thing when you're doing third molar extractions, okay? Forgetfulness when you're coming to class and trying to learn pharmacology is not a good thing, okay? So again, it could be a favorable or an unfavorable side effect. So the indications for Valium, insomnia, someone who's having trouble sleeping, take Valium, which will help them sleep. Or anxiety, so if they have a lot of anxiety, it can help to reduce that anxiety. Okay, let's look at nitroglycerin. We look at the primary effect of nitroglycerin. We learned about that in medical emergencies as well. The primary effect of nitroglycerin is it causes vasodilation. So if someone's having chest pain, we dilate those coronary arteries, we get more blood to the heart muscle, which in turn will get more oxygen to the heart muscle, and we can relieve that pain. Secondary effects is it lowers blood pressure. So if you have someone who is hypertensive and having chest pain, we give them nitroglycerin. It's going to help to relieve that chest pain by vasodilation, but it's also gonna help lower the blood pressure. If the blood pressure is too low, then it can cause problems. Several years ago, I thought I had a kidney stone. Went to the hospital, they gave me some morphine. The one and only time in my life that I have had or will ever have morphine. It gave me the worst chest pain I've ever had. So, because of the chest pain, they started giving me nitroglycerin. I don't have high blood pressure. So they gave me nitroglycerin, and then, you know that you can give up to 3 doses of the nitroglycerin, so they came back, gave me another one. They came back to give me the 3rd one, and I literally thought I was going to die. I could not lift my arms, I couldn't lift my head. All I could do was kind of turn my head. I looked at the blood pressure machine. My blood pressure was 48/21. If they would have given me that 3rd pill, I may not be here today. All right, so it can lower the blood pressure too much, which is then, now we have another situation, okay? It can cause hypotension, again, by lowering the blood pressure. Another thing it can do is, because it dilates vessels in the brain as well. Dilate vessels in the brain can cause headache. So a lot of people complain when they get nitroglycerin, they complain of a severe headache. Okay? That's an undesired. There would be no reason why we would want to cause a headache. So that would never be a favorable side effect. So what is the indications for nitroglycerin? Hypertension and angina. Okay? Are you all following how this works? Yep, good. All right, so now we're going to look at potency versus efficacy. Potency is the amount of drug that's necessary to produce an effect. So if you're comparing multiple drugs that all cause the same effect, the drug that takes the least amount to get that effect is the most potent drug. When we're looking at efficacy, we're looking at the extent of what the primary action of that drug is going to produce the effect that we want. So it's the maximum effect that the drug can produce and not anything more. So that means if we take a certain dose of a drug and it gives us the desired effect, if we give them any more of that drug, it does nothing. That would be the most efficacious drug. We'll look at an example of this here in just a second. All right, so here is a dose response curve for 3 different drugs. Drug A, drug D, and drug C. Drug A is the little black diamonds. Drug B is the blue squares. And drug C is the orangey red triangles. Okay? So we want to determine, or the goal of the drug is to raise heart rate, but only raise it by 30% and no more. All right? So, if we're looking at which drug is more potent, the desired effect is to raise the heart rate by 30%. So here's the line for raising the heart rate by 30%. The more potent drug will be the drug that you need the least amount of drug to get that effect. So when we look at A, B, and C, which drug gets us to that effect first?
B.
Drug B. Does everybody understand how we got that? Okay, so drug B is the most potent drug. So now we want to look at which drug is the most efficacious. So when we look at these drugs, which drug gets us to 30% increase of heart rate and no more? Drug C. Does everybody understand that? So if we take drug A, yes, it gets us to 30%. But if we take more, it just gets us even higher. With drug B, we take it, it'll get us to 30%, but then it'll get us, we take a little bit more, it gets us to 40%. Now we don't go any higher than 40%. So this drug B, is more efficacious than A. But the one that gets us to 30% and doesn't go any higher is C. So C is the most efficacious of these three drugs. Everybody following that? Yep. Okay. All right, so now we're going to look at receptor mechanisms and enzyme mechanisms for the drug action. We're also going to look at the term ligand, and then we're going to look at agonist and antagonist. So when we look at the mechanism of drug action, we look at receptors. Oh, hold on. We're going to look at receptors, enzyme, stimulation, and inhibition, and other. Let's go to receptors now. Okay. So when we look at receptor mechanisms, if a drug binds to a receptor in the body, that drug is a ligand. If the drug binds to a receptor in the body, that drug is a ligand. If it does not bind to a receptor, it's not a ligand. When the drug binds to the receptor, it's either going to cause a response or it's going to prevent a response. It's going to cause an effect or it's going to prevent an effect. If it causes the response, it is an agonist. If it prevents the response, it is an antagonist. So if you have an adrenergic agonist, that drug is going to bind to adrenergic receptors, and you're going to see a sympathetic effect. If it is an adrenergic antagonist, it will bind to the receptor, and it will either prevent or stop an effect. So if the effect has already started, the antagonist comes along, it will stop that effect. If the antagonist comes first, it will prevent the effect. All right, so if we look at ligands and agonists and antagonists, we do have drugs that our bodies make that are called endogenous ligands. The most common one is epinephrine. All right, we're going to look at some neurotransmitters also that are endogenous ligands. So that means these substances will bind to a receptor. When they bind to the receptor, they cause an effect. So an endogenous ligand would be considered an agonist. But it's not something that you inject into the body or get to the body. So it's typically not referred to as an agonist, but you kind of think of it in the back of your mind as it acts like an agonist. Okay? An actual agonist would be a drug that we give someone. When we give them that drug, it will bind to the receptor and cause an effect. If we give them an antagonist, it will bind to the receptor and prevent the effect. So if we have someone with hypertension, if we give them an adrenergic agonist, what would we expect to see happening to their blood pressure? It's going to go up. So a lot of the medications that individuals take are some sort of an antagonist because they block the receptor to prevent the blood pressure from going up. That make sense? All right, so let's look specifically at antagonists and how they work. You can have what we call a competitive antagonist. It's just what it sounds like. It competes for the receptor. It's going to compete with an agonist for that receptor. We can have non-competitive antagonists. So these will bind to a receptor, but they're not going to fight off an agonist. They're going to go someplace else. And then we have what we call physiologic antagonists. And physiologic antagonists are when you have two different substances that work by completely different mechanisms but have opposite effects. So we'll look at that here in a second as well. All right, so let's look at competitive antagonists. So here we have a cell membrane with a receptor, and that receptor is open and it's waiting for something to come along. So an antagonist comes along, we give them some sort of a drug that's an antagonist, it binds with that receptor. So now, with an agonist coming along, it can't bind to that receptor because the antagonist is there. So the antagonist competed with that agonist for that receptor, but the antagonist came first, so the agonist cannot bind. So let's look at hypertension again. We give them some sort of a medication that's an antagonist. It binds to that receptor. The epinephrine in your body tries to bind to that receptor. It can't because the antagonist is already there. And that's how it helps to keep the blood pressure down. Another way a competitive antagonist can work is, again, we have a cell membrane with a receptor. We have an agonist come along, and the agonist binds to the receptor. When that agonist binds to the receptor, some effect is going to occur. So then the antagonist comes along, it bumps the agonist off of the receptor, and now it binds to the receptor. And by doing that, it's going to reverse the action. Think of Narcan. You have someone who has overdosed on an opioid. They give them Narcan. The Narcan goes to the opioid receptors, kicks the opioid off of the receptor, and binds to it. And that's how it reverses the action of that overdose. Now, over time, this can get kicked off, and if there's still agonists around, the agonist can rebind to the receptor. And that's why when someone is overdosing and you give them Narcan, and they seem to be normal, they still have to go to the hospital, because 10 minutes later, they can go back into that overdose. Okay, because the Narcan does wear off. Now, with a non-competitive antagonist, the way that it works is that the cell membrane has two receptors. It has a stimulatory receptor and an inhibitory receptor. So an agonist comes along and it binds to the stimulatory receptor. So we're going to see an effect. The antagonist comes along and it binds with the other receptor, the inhibitory receptor. And by doing that, it's either going to reverse the action or it's going to diminish the effect somewhat. So a competitive antagonist, there's only one receptor. And the agonist and the antagonist are fighting for that receptor, and the antagonist wins. With non-competitive antagonists, you have two receptors. The agonist will bind to the stimulatory receptor. The antagonist binds to the inhibitory receptor. And by binding to that inhibitory receptor, it's going to reverse the action or diminish the effect somewhat. So, a good example is in the heart. We know in the heart, we have those beta-1 adrenergic receptors. So that epinephrine will come and it can bind to that beta-1 receptor, and what happens to the heart? Beta-1 receptor, we know that it is that stimulatory. So if epinephrine binds to a receptor on the heart, what's going to happen to the heart?
Increase the rate.
It's going to increase the rate and force of contraction, right? Okay. So we have cholinergic receptors. Adrenergic is sympathetic nervous system. Cholinergic is parasympathetic nervous system. So a cholinergic receptor would be an inhibitory receptor. So if the antagonist binds to the cholinergic receptor, then it is going to lessen the effect of that sympathetic response. So it will help to lower that heart rate and will help to lower the force of contraction. Okay, so this is non-competitive. There's two separate receptors that are not fighting over one receptor. But when you have the two receptors, one will be stimulatory, one is inhibitory. The antagonist will bind to the inhibitory receptor and it will lessen the effect. Now it's not going to stop the effect, because if we stop the effect, what happens to the heart? It's going to stop beating. Okay, we don't want that. Okay, so it's not going to stop the effect, but it does lessen the effect. And so this is how our bodies keep our heart in that normal pace. We know that we have that internal pacing from the SA node, but if our sympathetic nervous system just kept pumping and pumping and pumping, then our heart would be beating fast all the time and more forcefully. So this way, the agonist and the antagonist are keeping things in check so the heart is beating at that normal rate. Okay? All right, so physiologic antagonists, again, are two different substances or agents that are going to produce opposite effects, but they use two different mechanisms. The most common one to think about would be alcohol and caffeine. Alcohol is a central nervous system depressant. Caffeine is a central nervous system stimulant. So when someone has had way too much to drink, what's the first thing they try to do? Get them to drink coffee, right? So by giving them the coffee, the caffeine will hopefully counteract the CNS depressant and get them back to a more normal level. Okay? What happens if you give them non-caffeinated coffee?
No
You're
effect.
just gonna make them pee. There's no caffeine in it, so you're not getting that, you're not counteracting it. All right, so enzyme induction and inhibition. When you're looking at enzymes, the enzymes are not, it's not related so much to receptors. So an enzyme induction or reduction or inhibition medication is not a ligand, because it does not specifically bind to a receptor. So a ligand binds to a receptor, and it's either going to be an agonist or an antagonist. A drug that either increases the amount of an enzyme or inhibits an enzyme is not a ligand, because it does not bind to a receptor. So if we think back, when you have an injury, and you have damage to cells, and you have death to certain cells, what happens is there's an enzyme called phospholipase. The phospholipase will start to break down the lipids within that cell membrane, and it breaks them down into fatty acids. One of those fatty acids is arachidonic acid. All right, so you have injury, you have some cell death, the phospholipase breaks down the lipids within that cell membrane into fatty acids. One of those fatty acids is arachidonic acid. Another enzyme called cyclooxygenase will break down or convert arachidonic acid into prostaglandins. And couple the actions of prostaglandins is to cause pain and swelling. So when you injure yourself and you get pain and swelling, it's because of this process that occurred. So if we can find a way to block one of these enzymes, then we can hopefully either lessen or completely eliminate the pain and swelling. We can do that with aspirin and ibuprofen. Aspirin and ibuprofen block cyclooxygenase. When they block cyclooxygenase, the arachidonic acid is not converted to prostaglandins, and the patient will not have pain or swelling. Now, the thing to remember about this is that if they injure themselves, this process has already started. So by the time they've taken the aspirin and ibuprofen, they have already formed some prostaglandins. So the aspirin and ibuprofen will not take away the pain that they already have, because the prostaglandins are already there. It does nothing against prostaglandins. But what it will do is help to stop any new prostaglandins from forming, so the pain will become diminished and then it will go away. So that's why when we work on a patient, we have them anesthetized, and we know that the procedure that we did is going to cause them some pain afterwards. We tell them to take the medication before the anesthetic wears off. Because if you do that, then you lessen the chance of the formation of those prostaglandins. Okay? Alright, so we look at pharmacokinetics. So now pharmacokinetics is what the body does to the drug. So we're going to look at absorption, we're going to look at distribution of that drug throughout the body, biotransformation or metabolism or breakdown of that drug, and then how it's eliminated from the body. So we'll look at the most common routes of drug administration and explain the factors that influence the absorption of the drugs. We're also going to look at bioavailability and how it's influenced by the route of that administration. We're also going to look at what happens when someone takes a drug by mouth. Because when you take it by mouth, different things occur than if you take it any other way from the body. All right, so when we administer drugs to someone, obviously the most common one is orally. Someone takes a pill. The kids drink some sort of liquid, okay? We take it orally. Medications can also be given intravenously, so we give it into a blood vessel. Intramuscularly, so when you get a shot in the arm or the butt. Topical, transdermal, or sublingual is when you get the patch. Someone has a patch, or if you put it under the tongue, think of nitroglycerin, you put that underneath the tongue. Inhalation, you breathe it in. We talked about albuterol in medical emergencies where you inhale the medication. Subcutaneous would be just underneath the skin tissue. Rectally, we all know what a rectal medication is. Intrathecal means that you're putting it right into the spinal cord, the spinal column. And then intraperitoneal would be giving it into the peritoneum of the abdomen. Okay? All right, so when we look at oral absorption, when we take a medication by mouth, the mouth is going to go, or the medication is going to go into the stomach. All right? Depending on how lipid soluble that drug is, the more lipid soluble it is, the better it's going to be absorbed by the body. So if you think of vitamins, you have the fat-soluble vitamins and the water-soluble vitamins. The fat-soluble vitamins are absorbed better in the body than the water-soluble vitamins. So if you take too much of a water-soluble vitamin, it usually just passes right through and it's not an issue. If you take too much of the fat-soluble vitamins, your body absorbs them more. And that's why you always want to be more careful with those fat-soluble vitamins. You know, people take massive doses of vitamin C. Well, most of it they're just eliminating from the body. Okay, it's a water-soluble vitamin. The other issue with oral medications is once it gets into the stomach, we know that it's a highly acidic environment. Some drugs cannot withstand that acidic environment. Nitroglycerin is the most common one. We have to put nitroglycerin underneath the tongue because if they swallow the pill, the acid in the stomach will break it down and make it useless. So that's why it has to be given a different route. And then first pass metabolism. Once the drug has gone through the stomach into the intestines, it's going to enter the bloodstream to go to the liver. Okay, so it's going to enter the hepatic vein, which is going to take it to the liver. And the liver is going to break that drug down. So it metabolizes it. We're going to learn that some drugs have to be metabolized before they're active. Other drugs are not as active once they've been metabolized. So we have to look at first pass metabolism. What happens to that drug when it goes to the liver? How much of that active portion of that drug is left after it goes through the liver? With all the other routes, it bypasses the liver. So first pass metabolism does not occur with any of the other routes of administration. It only is affected by the oral administration. So here if we look at the different routes, we have an oral drug. Oral drug has to get into the stomach, withstand the acidic environment in the stomach, pass through the mucosa of the gastrointestinal system into the portal vein, which then takes it to the liver, and then it gets into the bloodstream. With a topical drug, it's sitting on the skin, so it has to soak through the skin, get into the connective tissue, which then eventually get into the bloodstream. With intramuscular or subcutaneous, it is injected into connective tissue. So subcutaneous is in that loose connective tissue underneath the other tissue, and intramuscular would be the connective tissue would be muscle. So it's put into the connective tissue and then it needs to get into the bloodstream. IV, you take the needle and inject it into the bloodstream. So what's the fastest route to get a medication into the bloodstream? IV. What is the slowest route?
Oral.
Oral. Okay, what is the easiest route for most people? Oral. Okay, and so, yeah, you typically don't have individuals at home that are injecting themselves IV with medications. So, we're gonna learn that when you give a medication, depending on the route that you use, you're gonna have to change the dosage of that medication in order to get a therapeutic amount in the blood. And we'll talk about that next week. All right, so when we look at first pass metabolism, we have an oral drug, gets into the stomach, withstands the acidic environment, gets into the small intestine, is absorbed from the small intestine into the portal vein, enters the liver will break it down. When it breaks it down into metabolites or these conjugates. Conjugates and metabolites are the same thing. We tend to use more metabolites. So, and then next week we're gonna learn that sometimes the parent drug is the active form and you really don't want it to be broken down. Sometimes certain drugs have to be broken down into metabolites because the metabolite is the active form. So we'll learn all about that next week. Once it's broken down, then the metabolites now get into the bloodstream and are able to do whatever they do. Because it's the first time it goes to the liver. Once it goes through the bloodstream, it'll eventually make its way back to the liver, where it's just broken down. Pretty much. So the first pass means that it went into the stomach, it got into the liver broke it down, and now it's ready to do its job. Okay? And Kelsey, did you have a question?
So like with the first pass, like it's specifically like liver based, like the liver is doing the work?
Yes.
Okay.
First pass metabolism occurs in the liver. All right, and we will talk a little bit more about first pass metabolism next week. Yes,
I
Debbie?
think I had misheard earlier. So you said the first pass is the liver in the bloodstream?
Yes, the first pass is occurring in the liver. Then, when it is broken down into the metabolites, that is the first pass metabolism. The metabolites enter the bloodstream and go throughout the body.
And the first class only happens with oral medication?
Correct. Correct. Yes, because when you give it IV, it's already in the bloodstream. When you give it IM or subcutaneous, it goes through the connective tissue into the bloodstream. And so by the time it makes it back to the liver, it's already done its job. Okay?
And is that why you would give like a higher dose of oral medication because then some of it's going to break
Yes.
down? Okay.
Yes, that's a good segue for next week.
Okay.
You're gonna learn that if you have to give somebody a medication and you have a choice of IV or oral, if you give them oral, you're gonna have to give them more because it's gonna be broken down through first pass metabolism. Yep. And we get to do math next week.
No.
Oh, I hate that.
All right. Any other questions about that? Like I said, we'll go a little bit more in depth with first pass metabolism next week.
I have a question.
Yes.
Not by experience, but,
Is that why you shouldn't take ibuprofen when you're drinking alcohol? Because it's just so much damage on the liver.